To thank Oxus for allowing me to present our data today, as well as acknowledge my co-authors. In this study, no author received anything of value for participation in this study. Multimodal pain management is using multiple medications to block the initiation, transmission, and reception of pain throughout the local, peripheral, and central nervous system, and has certainly been well established over the last 10 to 15 years. Periarticular injections have been shown to be a significant part of multimodal pain management. Benefits are well documented, but the perfect cocktail of medications has really not been elucidated. Liposomal bupivacaine is a local anesthetic designed for extended action. Liposomes are lipid-based molecules of varying sizes, act as a drug carrier, and release the medication over an extended period of time. It's been approved by the FDA for intraoperative injection. Several studies have shown benefit in general surgery, as well as in total joints, but most of these studies were not prospective or controlled, which led to our study question of, does a periarticular injection of liposomal bupivacaine injected around total knee reduce the pain, decrease narcotic use, and improve outcomes more than bupivacaine alone? We performed an IRB-approved prospective randomized trial. Patients and data collection staff were blinded. An important point is, prior to initiation of the study, we proceeded with over 192 practice cases where we used this medication. On 3 occasions, we had industry representatives there to help us perfect our technique. 111 consecutive unilateral primary total knees were involved in the study. The study patients received 20 cc's of liposomal bupivacaine and 30 cc's of plain bupivacaine, while control patients received 60 cc's of plain bupivacaine. Again, a standard periarticular injection was used for all cases. We used a relatively small or large gauge spinal needle, limiting the backflow. Half the medication was injected in flexion, posteriorly and into the subperiosteal femur. The rest of the medication in extension around the subperiosteal tibia, the posterior soft tissues, and in the subcutaneous tissue around the incision. All patients were involved in our multimodal pain management program with about 15 different modalities to help prevent pain and nausea postoperatively. Our primary endpoint was the visual analog pain score. Secondary measures included narcotic count, knee flexion, and hospital length of stay. Our statistics was provided by an outside statistician. If we look at our results, on post-op days 1, 2, and on the morning of day 3, we showed no difference between the study and control patients. Our narcotic use was equivalent between our studies and control patients. Our hospital length of stay was equivalent, and our disposition was the same. 97% of our patients went home directly, all but 1 in the study and 2 of the control patients. So the current study was a prospective blinded randomized study, found no benefit from liposomal bupivacaine over bupivacaine alone and a periarticular injection in primary knees. This conflicts with several reports in the literature that have suggested a benefit from liposomal bupivacaine. But several of these studies have methodologic concerns. Most of these are retrospective comparisons of sequential cohorts. Several are comparisons of dissimilar techniques, kind of apples and oranges, comparing a periarticular injection with liposomal bupivacaine and showing that superior to femoral nerve blocks. Previous studies have shown that a periarticular injection of plain bupivacaine is superior to femoral nerve blocks. So I think the conclusion here is a periarticular injection of any medication is superior, but not necessarily this study medication. Finally, several studies previously reported have potential conflict of interest. Authors, research, and publication were funded directly by the manufacturer. Entire journal supplements have testimonials without data. Periodicals have paid consultants saying that this medication is now the centerpiece of pain management in orthopedics. Certainly we know that studies with potential conflict of interest are much more likely to be published when results are positive. A recent report agreed with our conclusions published by Bagsby and Meneghini. Mike's group showed that 150 primary knees, these were looked at retrospectively and were sequential cohorts, but showed no benefit from changing their periarticular injection from bupivacaine to liposomal bupivacaine. Why do these 2 studies have negative results? Mike theorized that liposomes have slow release of medication, which may limit their bioavailability. Previous studies have suggested that liposomes may modify the medication and limit its activity. Finally, as part of a robust multi-medical pain management strategy in which we're already employing 15, 16 different modalities to reduce pain and nausea, one more treatment may have limited effect. Periarticular injections have been described for over 10 years, but have had relatively slow adoption of this technique. The audience response at this very meeting 2 years ago showed only 61% of surgeons who are hip and knee specialists are using a periarticular injection. It'll be interesting to see what Dan finds out tomorrow. National rates of periarticular injection are thought to be lower. Previous reports on periarticular injections use generic medications. The liposomal Bupivacaine cost our institution $285, where the control patient medication was $2.80. As we're involved in ACOs, I'm involved in several bundled payment programs at risk in some contracts. It's hard to justify the routine use of this medication. So in conclusion, prospective randomized periarticular trial of liposomal Bupivacaine showed no improvement in pain management over plain Bupivacaine. The cost associated with this could not be supported by this study, and it's no longer used in our multimodal pain management program. Thank you.
Excellent. Our next talk, tourniquet use during TKA and its effect on recovery of quadriceps strength and lower extremity function, Dr. Charlie Yang.